Picture this. A patient walks into your dental clinic complaining of pain in his wisdom tooth, and you tell him he not only has to extract one but two of his teeth. This could be in up to 50% of cases based on the research done in Jordan, which means it could be me, or even worse, it could be you. A very good morning to honorable judges. My name is Wan Yee, a final year student from SEGi University, and today I will be presenting to you our research with the topic Prevalence of Caries on Distal Surface of Mandibular second molar in patients with impacted mandibular third molars in SEGi Dental Clinic. These are our group members and our supervising advisor, Dr. Daniel. As we all know, impacted mandibular third molar is one of the most common encountered in daily dental practice. In fact, a study by the Oral Surgery Institute of Carolina said that 90% of the people have at least one impacted third molar. So, should we, the dentist, always advise the patient to remove the impacted third molar or retain it? Let's first understand how this hypothesis began. We have found out that, according to different authors, most of them think that removal is indicated, but they could not give a general indication, and some of them have concluded that monitoring of such impacted third molar is required. Here is a long list of reasons why dentists should always be alarmed when it comes to impacted third molar, and as we can see, caries in relation to the adjacent tooth is on top of the list. This brings us to the aim of our study, which is to evaluate the relationship between impacted mandibular third molar and distal caries in the adjacent second molar. Our objective will be to analyze the prevalence of distal caries on mandibular second molar in relation to impacted third molar based on the Winters and Pels and Gregory's classification. Also to assess the need for removal and retention of impacted third molar. Moving on to our methodology, this is a retrospective study analyzing 65 digital orthopantomogram of adult patient visiting SEGi Oral Surgery Clinic from March to April 2021. Of these 65 OPG, 95 impacted third molars were observed. Assessment of mandibular third molar was done based on Winters classification and Pels and Gregory's classification. As for the assessment of caries, only obvious radiolucency and radial opacity on distal surface of adjacent second molar, which indicates past caries activity, was taken into account. Statistical analysis was done using SPSS version 22, chi-square test was performed, and p-value less than 0.05 was considered significant. This is a diagram to explain the PG classification and Winters classification. Here is an example of a mesioangularly impacted third molar with PG class 1A and an associated distal caries. The left photo is showing a carious third molar and distal caries on the adjacent tooth. Next is our inclusion criteria. Age group between 18 to 47 years of both genders and different ethnicity was included in our study. And there should be presence of mandibular second and third molar, and there can be presence or absence of distal caries in relation to adjacent second molar. For exclusion criteria, it is excluded when the adjacent second molar is absent, when the caries is on other surfaces of mandibular second molar, and when the factors causing the distal caries are found to be caused by other pathogenic causes. Lastly, buccal and lingual inversion of impacted third molar are also not taken into account. Next is our result. Out of the 65 patients that we examined, 34 of them are male patients and 31 are female patients. Regarding the prevalence of distal caries in different classification, let's first come to the Winters classification. Here is the prevalence of distal caries in different angulation in a table form, and the p-value is significant. This is the result in a graph form. We can see that the mesioangular impaction has the highest association with distal caries on adjacent second molar, which is 48.5%, almost close to half, followed closely by the horizontal type of impacted third molar that has 44.1% association with distal caries, and vertical impaction which has 7.4% association, and lastly, distal angular impaction that has no association with distal caries. As for PG classification, PG1A has the highest association with distal caries, which is 51.5%, followed by PG2A that has 24.2% association. However, unfortunately, the result was not significant, probably due to small sample size. Moving on to discussion, in our study, mesioangular impaction was most commonly associated with distal caries, followed by horizontal, vertical, and lastly distal angular impaction. This can be seen in few similar studies also, as shown in the table 1 below. In another study by Rahim et al., most of the distal caries in second molar was caused by the horizontal impacted third molars. For PG classification, in other studies, level A and B show similar percentage of association with distal caries on adjacent second molar, which is ranging from 38.6% to 45.8% in different studies. In our study, level A and B takes up 81.8% and 15.1% respectively. As for relationship to anterior border of ramus, in other studies, class 1 shows significantly more association with distal caries. And in our study, class 1 and 2 takes up 54.5% and 36.3% respectively. It has been well documented in other studies that the angulation and depth of impaction play a major role in causing distal caries in adjacent tooth. This is due to increase in ease of food retention and hence the growth of bacteria. And the tooth location also does not allow accessibility of oral hygiene measures. Another study also said that impacted third molar is associated with certain bacteria and inflammatory mediators that can cause caries. On the other hand, when the impacted third molar is not in contact with the oral environment, such as in PG level C and class 3, the prevalence of distal caries is almost close to zero. To prevent progression of caries, it has been documented in other studies that regular review and routine bite-wear radiograph are very important. Proper oral hygiene measures should be carried out by the patient as well. Of course, prophylactic removal of mesioangularly and horizontally impacted third molar is the best way to prevent caries. With that being said, the limitation of this study include the use of panoramic radiograph in detecting interproximal caries. Hence, this could lead to an underestimation of diagnosis of distal caries in second molars. A more accurate analysis can be performed with the help of intraoral periapical radiograph or a combined CT. This study is designed retrospectively. A prospective study design with a long-term follow-up can be advised as a better option. Lastly, our sample size is also insufficient to provide adequate data on prevalence of distal caries in relation to distal angular impacted third molars. Conclusion, this study shows that there is an association between distal caries and mesioangular and horizontal type of impaction. Detection of caries is not the end of the story because when the caries progresses, there will be incorporation of different specialties such as operative dentistry, endodontics, or even worse, oral surgery department. The cost of rehabilitation will also be significantly higher. Lastly, from our side, we will recommend prophylactic removal of mesioangularly and horizontally impacted third molar, especially when it is PG level A and class 1. And diagnosis and treatment planning is of utmost importance when it comes to preserving the impacted third molar and the adjacent second molar. These are our references. I would like to thank the Dean of Faculty, Dr. Daniel, Dr. Priya, MIDEC committee, and all attendees. Thank you.